to our core seminar. It is my great pleasure to introduce to you Dr. Sylvie Lambert, who is an associate professor and associate director of research at the Ingram School of Nursing at McGill. She is also a scientist at St. Mary's Research Centre in Montreal. Sylvie is also the recipient of a CIHR Canada Research Chair Tier 2 in self-care and illness self-management support interventions. In this position, her research program focuses on developing and evaluating low-cost self-care and illness self-management interventions that are sustainable to enhance translation in practice, implementing real-world interventions, patient-reported outcome and caregiver-reported outcome screening programs, adapting evidence-based self-management interventions to the needs of patients from culturally and linguistically diverse communities, and using advanced psychometric approaches for improving the precision and efficiency of outcome evaluations. Sylvie has secured more than $7 million in competitive funding. She has worked significantly to advance the fields of patient education, caregiver research, and self-management interventions, contributing to improved outcomes for patients and their families. Welcome.
Thank you, Katya. I'm really happy to be here today and have the opportunity to present to you in person as well. Oh, online. I'm okay with the aim of the camera. Now I see my back. To present on smart design. So they're an innovative trial design, and we've been using them particularly to design adaptive self-management interventions for patients with cancer or psychosocial interventions. So we know that psychosocial interventions for patients with cancer are effective, and they are usually very complex intervention that have multiple components. So you might heard of self-management, symptom programs, potentially smoking cessation programs, physical activity. At the RI-MUHC, there is a very large psychosocial intervention research program as well as clinical programs. So we put in place these interventions. And we know from systematic reviews and meta-analyses that these are actually quite efficacious with effect sizes ranging from small to moderate. But typically, psychosocial interventions are what I consider packages, and we typically pitch the package. So by package, we mean different types of potential intensity, mode of delivery. So we might give a login to a website to learn how to do cognitive behavioral therapy to manage anxiety. We might give a CD-ROM. We might call them 3 times. We might send them 3 emails to remind them to log into the intervention. So we just kind of throw this at patients, and sometimes we monitor the extent to which each component are used, but that's what I refer to as multi-component and also like a treatment package that we just try to evaluate. So traditionally, all of our meta-analyses, I would say most of the studies, if not all, are done in a way that these components are packaged, we pitch the intervention, and then we evaluate through a parallel, typical randomized control trial. And so, which is okay, but that also means that we're not able to necessarily differentiate the different components. So we send the intervention remains the same, no matter whether people respond, don't respond, like it, don't like it, we just stay the same. They go, they do their intervention, as most of you when developing or designing randomized control trials. So the problem with this is that, especially in a context where we have a lot of components, we don't know which component was efficacious. We don't know if all of it is needed. We might not need all of this huge package. Maybe there's one thing that was efficacious. And yet, so instead of pitching a package that's costs, I don't know, $100 per patient, maybe we could pitch a package that's $50. It's just we don't know that the component that we need is potentially the least expensive. And if it's not efficacious, well, we still don't know if some components might be worth keeping. We don't know if maybe one component had a negative impact on another. So we know in these psychosocial interventions that if it takes too long, if it actually creates burden, we can actually create burden by pitching this package to patients. And then we see that their anxiety actually increased in the intervention group. And we've seen trials that way where the intervention actually led to worse outcomes. And when we've interviewed patients, it's the burden, it's the time. It reminded me doing these things or seeing this information reminded me that I have cancer, that I have anxiety, that I have all these symptoms, right? But we don't know if underneath all of that, there's actually a gold nugget there, and it just got buried with all the other components. We don't know what went wrong, and we don't know if some patients might benefit. So adjusting to cancer is very dynamic. We know it changes from day to day or week to week, but yet our interventions are not dynamic because we want this rigor of the randomized control trial, so I can tell you at the end, which is really important. However, there's a way that we can start thinking of our interventions a bit differently, but maintaining the rigor that comes with a randomized control trial. And that is adapting our interventions over time. So an adaptive intervention is our sequential interventions that are changed or repeatedly changed over time based on an individual's response or non-response. So we're trying to really move away from this one-size-fits-all approach, and also adapting might involve adapting the timing, the intensity, the mode of delivery. Any of the components that I spoke previously could be adapted in one way or another. And one of the most well-known adaptive interventions that are actually used in practice, but we don't really test them well in research, is what we refer to as a step care model. So a step care model is the right intervention for the right patient at the right time, trying to use the least intensive intervention first, and then changing it based on patient's needs. So often that might look at, if we're thinking of anxiety or depression, for a step one, that might be active monitoring. So we might wait, the initial shock of a cancer diagnosis. It's normal to see the anxiety increase. And maybe after a couple of weeks or a couple of months, this anxiety will decrease and no intervention will be needed. Step two might be, well, we might give them a booklet on how to manage your anxiety. Some patients will respond to this, and we know about, up to 50, 60% of patients, this is the step that they need. Some patients will need a little bit more. So maybe this is self-guided self-management, for example. So someone might call you, say, hey, how are you doing? So we might do maybe online intervention or maybe group intervention. That doesn't work. That will work for a certain percentage of patients. For those that it doesn't work, maybe here we're left with maybe 25% of patients that need then more higher intensity psychosocial intervention. So this is where maybe it'll be a one-on-one session. And often only 10, 15% of patients get to step 5, which is then a specialized referral or services. But this is what we mean by an adaptive intervention. So we assess people's response, people's needs. Some people don't need it, great. So what do those people receive? They might receive maintenance of some sort, but then some individuals are stepped up to the next phase. It's very hard to test this in a randomized control trial in the way that it is now, or the way that it's designed. There's 4 components to an adaptive intervention. Our decision points, so when do we decide to change the intervention? Tailoring variables based on what? Level of anxiety. Maybe we based it on the fact that you've learned coping skills. So you have to decide on what variable you use to change your intervention. What is the option? What is the next option that you will offer? Are you using an overall stepped care approach? Maybe not. And I do want to say that when we cover SMART, we also see it, I'm presenting it in a psychosocial, but we also see it with medication, right? So we'll start maybe with cognitive behavioral therapy, then we'll change to a medication, a first-line treatment, a second-line treatment, a third-line treatment. So there's actually a lot of SMARTs that I'll present in pharmacology in terms of treatment as well. So it applies to a lot of different situations. And then a decision rule, which links everything together. So what will you offer, when, to who, based on what? So how do we answer these questions, or how do we then develop our adaptive intervention? That's when SMARTs come in. So SMART stands for Sequential Multiple Assignment Randomized Trial. And this is how we develop our sequence of intervention to optimize our interventions. So what you see here is a typical, the figure that you see at the bottom here is a typical SMART, where individuals are randomized to at least 2 stages of interventions. So you see here initially they're randomized to A or B, so that's referred to as the first intervention stage. Then based on response or non-response, they are based on the tailoring variable at a decided upon critical decision point, they are then randomized to stage 2 options. And at each stage, there's one or multiple interventions. So if we take our step care model before, so I might randomize people to step 1 or step 2. I might be interested, is a very minimal intervention versus a minimally guided intervention equivalent. And then depending on response, I might then randomize them to a step above, or I might randomize step 1 to step 2. So then it depends on your research question, which combination that you're interested in. I have lots of examples from our own research to show you in the next slides. So in this kind of design, there's what we call 4 adaptive interventions. So first, I'm randomized to intervention A. If I'm a responder, then I go with C. If I'm a non-responder, I'm randomized to D. So that's 1 adaptive intervention. My second adaptive intervention is I'm randomized to A. If I respond, I stay with C. If I'm a non-responder, I go with E. So that's my second. So really, your adaptive interventions are your routes here, right? So I can go this way or I can go this way. B, same thing. I'm a responder, I go to F. If I'm a non-responder, I go to G. Or I'm a responder, I go to F. I'm a non-responder, I go to H. So that gives you 4 different adaptive interventions. And when you're fully powered, then you're able to test the difference between these 4 adaptive interventions. Any questions? You have plenty of time. Yep.
What's the difference A and B?
So it's whatever interventions you're testing, right? So I'll come with examples later, but this could be like a web-based cognitive behavioral intervention versus usual care. Or maybe I want to know if I log into a cognitive behavioral intervention versus 3 sessions with a psychologist. Like it just really depends on your research question. And same thing for C. So either as a responder, I either continue with my first stage intervention here, or if I'm a non-responder, usually I continue with my first stage or I'm stepped up. Okay, any other questions?
Hi, thank you. It's very interesting. I was wondering for sample size calculation, is it the same as traditional clinical trials or different?
No, the difference is that it's a bottom up approach or a right to left approach, right? Because I have to make sure that I'm powered here. And in my example, I can show you later, and you might have different effect sizes, right? As well, because this is usually more intense. So you expect a higher effect size here, and then you work your way backwards.
Thank you.
But it's still less than if you had, because to test this, you would need 2 or 3 separate randomized trials. It's still less than that, but it's more than just 1, yeah. So there are different designs in SMARTs. Like this one, the responders are not re-randomized, but you might want to re-randomize your responders for whatever reason, right? Again, it depends on your research question. So I'm a responder, but you might want to step me down. So some people test starting out at a step 4, a step 5, and then stepping people down if they respond, right? And I've had that in grant applications where I use a step up, and one reviewer said, well, why not a step down? So this potential kind of design could help you test a step down, maintenance, boosters, you're calling people once or twice in the next 6 months after a physical activity program maintains the level of activity program that you saw during the active phase of the intervention, for example, right? So this kind of design would help you. And you don't have to randomize both arms. Again, it depends on your design. So maybe A is the gold standard, and you want to see if you start testing it against another combination, another adaptive intervention. So there are different SMART designs. The important thing is that you have at least 2 randomizations for 2 stages of intervention. That's what defines a SMART. So SMARTs are not factorial designs. True in a factorial design, you are randomized to a combination of interventions. However, you stay in that group, right? You are in A1, B1 for the duration of the trial. Yes, it allows you to start differentiating some components. So it's already, they have that in common, but SMARTS, your intervention changes over time. Similarly, SMARTS are not crossover trials because crossover, the participant will get both treatments, whereas in SMARTS, if you respond, depending on your design, you might not get all of the interventions. So I'll give you two examples from our research program. So my research program is focused on self-management. And so for sure, self-management, if I have 10 sessions with a nurse and that teaches me how to manage on a day-to-day basis when I'm at home, all of the issues that I might have due to cancer, that's probably going to be efficacious, but we're cutting programs constantly, and that is just not feasible. So that might be like the Cadillac. I'm trying to find like the Honda that I say all the time, right? That'll get me from A to B, that'll last for years and years and years and years. And so that's why I'm particularly interested in adaptive intervention and in SMARTS. So we know self-management is the first line intervention. If you look at clinical practice guidelines, anxiety, depression, pain, a lot of these will start at step one. Well, first of all, they'll use a step care approach to the treatment of all of some of these conditions, and they'll often start as step one as self-management. But we know that most patients and their caregivers do not know how to self-manage, do not get the information that they need to self-manage. So it leads to a really bad, vicious cycle of trial and error, and efficacious strategies that are not efficacious. And so we're trying to break that cycle by finding the best adaptive intervention that we can use at low cost, sustainable within the current cost containment climate of the healthcare system, and that it won't be the first thing on the chopping block due to budget cuts. Most of my intervention, or all of my intervention, also includes caregivers. So we know again that caregivers are more and more relied upon by patients and healthcare professionals, especially in cancer when there's most treatment are through ambulatory care clinics, and more complex treatment are also provided in an ambulatory fashion. There's some treatment that actually requires a caregiver 24/7 for 2 to 3 weeks. So some, not all centers, but for example, CAR-T or immunotherapies, they do require a lot of a presence of a caregiver. So there's a lot on their shoulders, and they don't have access to support programs. So again, I'm trying to find ways in which we can support them despite the burden. I'm particularly focused on steps 1 to 3 in a step care model. I'm not so much ending up here with the very intense healthcare professional-led interventions. I'm really trying to see, well, how many people can we have an impact on by really well-designed adaptive stepped care self-management intervention? If I get here and I have 75% response in low intensity kind of interventions, then I'll be really, really happy. Absolutely. I'll get that with my example of tempo. So I'm at 376 at the beginning of tempo. Yeah. Yeah. Nobody's allowed, you're not allowed to laugh. And actually, it just got launched today. So the trial, it's a pan-Canadian trial. And because of that, we did partner with the Canadian Cancer Trial Group. So it is in partnership with the Canadian Cancer Trial Group because we have like 18 centers that'll be helping us in recruiting. So yeah. There. But, we're also looking at very small differences, like in the scales that we're using. So that's another reason why it's requiring so much of a large sample size. So it does depend on your primary outcome. Okay, so 2 examples of SMARTs that we did and what we learned. So tempo, it's more of a protocol, but we did do a pilot SMART. And this pilot SMART was funded by CIHR in like 2016, 2017, when CIHR was launched a competition through their SPORE group because they wanted trials, innovative trials, like trials that were not RCTs. And so we submitted for a SMART I just started working with SMARTs. And I did partner with Erica Moody, who's a biostatistician at McGill and specializes methodologically in this design. So coping together is really what it tries to do. It translates the evidence we know works when you're trying to self-manage over 49 different cancer challenges, from anxiety, depression, most physical symptoms. How do I talk to my healthcare professional? For caregivers, what do I do if the patient starts to cry? What do I do if we suddenly fight more, the patient and I? So really, really divided across different booklets. And we have a workbook that helps patients, again, and their caregivers learn these different strategies. And so this is our smart design that we use. So this is a pilot that we did. So we had a small sample size, 48 dyads that we randomize in first stage intervention, 1-to-1. One member of the dyad needed to declare some level of distress. We screened with the distress thermometer, so they needed to have a score of 5 or more on the distress thermometer. One member of the dyad. They were then randomized 1-to-1 to receive coping together only. So that's my step 1. But I also wanted to see whether there was an advantage of adding lay guidance. So by lay guidance, it's a non-healthcare professional that we train. This is a model we've developed at the St. Mary's Research Center. And it's someone we train, and they call patients and caregivers. Hey, how you going? Have you opened the package? Because you're not going to have an effect if it stays in the package, right? Did you open the package? Did you read the booklets? Did you identify a challenge? No? Okay, let's look at it together. You identify a challenge. Great. Did you identify a strategy to manage your challenge? No, you didn't have time. Well, let's look at it now together. We have 20 minutes. These are short calls, 15, 20 minutes. And dyads get 8 calls. So then 6 weeks later, we measured 6 weeks is our critical decision point. And then we measured our tailoring variable. Our tailoring variable was whether there was a change in the distress from the baseline to 6 weeks. And so we gave the distress thermometer again. And if people had a decrease of at least 1 point, and which is clinically significant, then they were a responder. This is a dyadic, right? They're a dyad. So as long as the other person is now not distressed. So if they became distressed, then the dyad was declared non-responder. So the added complexity that we put is the dyadic component. So both members of the dyad can't be distressed at the critical decision point. So in the second stage, if you were a responder, you continued with your first stage intervention. So coping together, dyads, we're told continue using the booklet, whatever challenge comes up, continue doing what you're doing. Lay coaching dyads receive 3 booster calls during the second stage. However, if you were a non-responder, you were randomized to continue with coping together. Maybe you need more time. Like it takes time to go through these, to learn, so maybe you need more time. So that's what we're testing here. Instead of a 6-week intervention, maybe we need a 12-week intervention, right? We often not randomly, but we often arbitrarily actually decides on some of these, the lengths of these intervention. We have very little evidence to say whether 6 weeks or 12 weeks is needed for these kind of interventions. So maybe 6 weeks is enough. Maybe I need 12 weeks. If I'm a non-responder, then I'm going to give you lay guidance. Right? Then you'll start getting the calls of the individual. So here I'm testing step 1 and then being step 2. If you were receiving the booklets and lay guidance and you're non-responder, again, try to stay with the lay guidance for 3 more calls. So maybe instead of 8, 11 calls, that's what I'm testing. Again, very little evidence to guide that kind of decision making. And if not, then I switch you to motivational interviewing, nurse-led motivational interviewing. So we're getting into step 3/4 here because we're introducing a one-on-one telephone call with a nurse. And then we measure the outcomes. So what we learned, again, this is a pilot, so we're very limited in terms of but there's still some nice trends that we saw in the data. So when we look at response, we actually got higher response in the booklet-only group than in the lay guidance. And this is what I was telling you about earlier, right? If we go too intense, too quickly, too strong, we've been noticing this in a lot of psychosocial trials. So 70%, like I mean, but this intervention has been in the making for a long time. So I think we've hit a sweet spot in terms of too much information versus not too much, and how people can digest information when they're stressed, they're tired. Like this is, you know, for some of them, their world has changed drastically overnight. So I think it just shows we're having a sweet spot. The lay guidance requires you to be on the phone at a particular time for 20 minutes, right? So, and we did interview some dyads afterwards, and that was definitely something that they mentioned. Is there an advantage to stepping people up if you haven't responded? Again, small sample size, very small, but what we've noticed in terms of trend is that all patients stepped up did improve. So again, potentially to be confirmed in a larger SMART, but it looks like stepping people up was more worth it than staying in their intervention. No.
So can you just too quickly, and maybe you want to provide more details later. So what kind of selection issues are you seeing in terms of older, younger, whoever doesn't want to even participate? And then you mentioned that those that are engaged do better, but do you think there's some selection bias there too?
Yeah, no. So thank you for asking the question. So actually, we'll see in the next slide, those that engaged did not do better, because if by engage you mean adherence to the intervention. Yeah. You mean here? Oh, because it didn't even engage in the, so we didn't actually see a difference in terms of engagement in that sense. So they were measured in terms of their distress. So if they still had some distress, then that's how they were stepped up or not stepped up. But in terms of their age, in terms of their income, like we looked at all of that, there was no difference between those that were not stepped up versus those that were stepped up.
You mentioned that some people are overwhelmed and they won't even engage at the start. But if you offer to step up, is there that same thing where people, they need to have stepped up therapy, but they're too overwhelmed?
Yeah, no, we did not find that. No.
Oh, great.
No, not in the patients. We did in the caregivers. Not in the patients. Yeah. So you bring up a really, really, really important point. So that's where we're trying to find that sweet spot, right? Like who needs what when. So right now, based on these findings, my step one is not the lay guidance. So the step one that we're testing in our larger trial is starting with self-directed. Because for some people, calling them was a stressor, but in terms of stepping up, we didn't see a difference in terms of that. It's when we called them after. And I think that's why we have a lower response. There's still a 13% difference between lay guidance and self-directed, and I think that's why. Did I answer the question? Yeah, okay. Yeah.
Thank you. My question pertains to the larger trial. Do you compare responses to just usual care?
Well, I'll get to that. So and very quickly, and we might have some, so obviously this is a pilot, so we were much more focused on acceptability and feasibility, and we also had a prior benchmarks, and I just wanted to flag some that are quite interesting. We didn't reach our recruitment, but it was amidst COVID. We didn't also, in terms of men, women, we wanted 40% men, 60% women. We didn't quite reach that for patients. We did for caregivers. But just some interesting trends. The helpfulness was higher in the lay guidance. So this is the conundrum, I guess we can say. So like the lay guidance was more intense and people were more stressed, but they also found it more helpful, right? Because someone forced them to look at the intervention. Adherence was higher in the lay guidance group, but it didn't translate in higher response. And I think it's more to the question that was asked in terms of like it stressed people out though, because it did ask them to do a lot. And there's a potential differential effect between the patient and the caregivers. The caregivers I think they're just too overwhelmed, too burdened. Being on a call with someone, it was just, so there's no clear trend for the caregivers in terms of being stepped up or not, but there are for the patients. So right now, based on our pilot, again, this is a pilot, I would suggest starting with self-directed, coping together, add lay guidance, and then add motivational interviewing. So this, for now, this is where I'm at. So our second trial, how am I for time? Oh, we're plenty. Okay, perfect. So our second intervention that we're testing is called Tempo. So this is a tailored dyadic web-based physical activity and psychosocial self-management program for men with prostate cancer and their caregivers. Again, it was developed to increase their repertoire of self-management skills and increase physical activity to meet guidelines. So this is a schematic representation. Tempo is 6 modules. So patients and caregivers log in with their own login to the website, but they see each other. It's like my courses, or you see everything that everybody sees, but it's only for the dyad. So they log in with their own login, so we know their level of use. They log in, module 1, they complete a survey and asking them about 49 needs that they have or challenges. Then they are, for each need, there's a fact sheet to help them know how to self-manage that challenge. So very much taken from Coping Together. It's just this is the 2020 whatever version, or 2015 is when we got the first funding for this this intervention. So it's the online version of Coping Together. So they go in the health library, they can find their fact sheet. In module 2, then we ask them to set a goal. So we all know we should exercise, we all know we should do mindfulness, right? It changes your brain composition, and I still don't do mindfulness. And so we help them say, okay, well, this is your challenge. Which strategy are you going to use to manage that challenge? And then they set SMART goals to then achieve those challenge. And the double T is not a typo. This is for together, right? Because they're dyadic. And then in module 3, they do an action plan. So when are they going to do their physical activity or whatever else self-management strategy that they decided. We hope that this will lead to increased action. And then modules 4, 5, 6 is all about dealing with barriers. If you encountered barriers to achieve your goals, mobilize the support you need. Maybe you need more support to achieve your goals, and then celebrating successes. Then we measure health outcomes. So that's the mechanisms of action of Tempo. That's how we hope it will lead to better health outcome for patients and caregivers. And this quote from this patient really summarizes the crux of what we hope to achieve with Tempo. So this patient said, Tempo helped us see what was important. When it is important, you want to learn what to do about it. As you get more comfortable about it, you get less anxious about it. And so Tempo, we did a feasibility study initially, like would people even use this? And what was flagged is that Tempo is a useful one-stop shop. So it prevents Dr. Google, is often the example that patients and caregivers give us. It has all the credible information you need in one spot. And also dyads endorse the self-directed. Again, most patients and caregivers that we interview say, well, I refuse to go to the support group, or I don't want to do this, but this I did do because it was in comfort in my own home at our own pace. I've had people decide to go on weekend getaways. That's not what I would not do Tempo myself. I developed it. I would not do it. But that's what some patients and caregivers did. And they went through Tempo together at selected times. Then we did a pilot randomized control for Tempo. I wasn't using SMART as much in terms of timing of years, but overall, again, this is a pilot. So we had a priori benchmarks mostly focused on feasibility and acceptability. We didn't meet our recruitment one. Again, this was also launched amidst COVID. And we also, the other benchmark that was low is the one on adherence. And what we heard is that, going from one module to the next, and it requires work to go through the different modules, and some people had difficulties with some of the modules, so then they just let it go. So we do have like 75% adherence for module 1, then 60%, then 40, then 30, then 20, then 10, right? Which gives us the average of about 45. But obviously, adherence at the beginning did meet our benchmark of 75 for module 1. So we have initial adherence. So again, thinking of developing or having the Honda version of the self-management intervention, we're thinking, okay, we know we're able to get people to get on to tempo and start, but they seem to have hurdles. So what if we add, again, non-healthcare professional guidance to tempo? So again, this is my smart design. It's different from the other one because here so today it was launched officially just before I came here. So we did get CIHR funded for this trial. So we are planning on randomizing 376 dyads. The allocation ratio here is 3:1, just because we need more people to trickle into these groups than here to answer our research question. And again, one member of the dyad needs to be anxious or have some struggling a little bit. And this is measured with the Edmonton Symptom Assessment anxiety item, because this is what is used in most cancer centers and clinics. This is the scale. Again, thinking about translating the study into real world. And so on first stage, dyads are randomized to tempo only or to usual care. So you were asking me in terms of usual care. So it doesn't have to be 2 interventions. It could be usual care because I still want to document. I've only documented tempo's acceptability and feasibility. Now I want to document its efficaciousness against usual care. And actually, when I submitted, so I needed to go 4 times to get this funded. The first time I submitted it, there was just smarts were new. They're still new. So the reviewer said to me, you can't compare an intervention against usual care in a smart, and that's false. You absolutely can, and you could see it as you're varying the timing potentially of the intervention. So that's a methodological note. And then in terms of so they'll be with the tempo for 12 weeks. There's 6 modules, 2 weeks per module. Then the tailoring variable is ESAS, anxiety, on week 13, the week after the intervention is done. So we measured anxiety. 1 member at screening, 1 member has anxiety. They're in the trial. Decision point, tailoring variable, as long as there was a 2-point decrease for the person that was anxious and the other person is still not anxious. So if the patient was anxious at the beginning of the trial, let's say his score was 4 on 10 and now is 2 on 10, he's a responder. Then we have to make sure his caregiver is also a responder. So if the caregiver had 0 in the anxiety item and they still have 0, great. But if there was an increase in the caregiver, even if there was a decrease in the patient, you go in. So we have a statistician that programmed this all for us so that we just enter the scores and they tell us whether you're a responder or not, because again, the complexity of having a dyad. And the reason for that, and that was another comment I used to get, is that it's because we know there's a high correlation actually. And we saw this actually in our Coping Together pilot, that as soon as one member is anxious, sometimes it doesn't take very long for the other member to become anxious as well. They're an interdependent emotional system. So that's why we just have to make sure the other person is still okay. Second stage, if you were a responder, you continue with tempo. If you responded to usual care, nothing else happens. You just complete at the end of the trial your measures. If you were a non-responder, then you're randomized to continue with tempo. Maybe you need more time. Again, I'm still testing that. Or you switch to tempo plus lay guidance to help you through tempo. And if you're a non-responder to usual care, you just get tempo right away. And then we measure the outcomes in 3 years from now. So, because we need 376. Our questions, my first research question, or my primary one, is whether tempo is more efficacious than usual care. My primary outcome is anxiety, but also on secondary outcomes and whether it's cost effective. Then I want to know if more time with tempo is, well, actually it's lay guidance. I want to know if adding lay guidance after 12 weeks is more efficacious than just giving you more time. The same thing for cost effectiveness. And then we'll be testing different adaptive interventions if we're powered enough. So for the sample size calculation question, so the way we did it for this one is that we made sure we were powered here, because this is our secondary question, I'm assuming here an effect size of 0.4. I think it's 63 per group, and then working my way backwards, accounting for all my attrition, and then making sure I have enough for tempo versus usual care. My effect size there, I'll be really, really happy with 0.35. So that's what we calculated. And then you have to assume a response, right? Because if I have I assume I think a 60% response here. So like that's how you end up then with 376. So if I need 63 here, and I'm assuming a 60, that means I'm only at 40 here, plus. So any questions for tempo?
Hi, Tanya Janautsui, I'm a scientist here at the core. You mentioned about adherence in your previous trials, but what is the dropout rate in what have you noticed in your trials?
24% dropout, like people that are like non-contactable.
Okay, so that's you use it for your sample size calculation. Yeah. Okay.
There's definitely a dyadic effect that brings in. So sometimes, and sometimes one member of the dyad will stay in the trial and not the other, like the other person is like dropped out, so that happens as well. So I still consider the member that stayed in the trial. But yeah, so on average, 20 to 24%, a little bit higher for the caregivers.
Okay. Thank you.
Yeah. So in the usual care group, in the end offered tempo. So this group
is a waitlist control group.
It's not a crossover?
No.
Okay. So it's your intention to treat.
Yes.
Okay.
So I just wanted a couple notes on selecting the tailoring variables. So our general theoretical framework is the stress and coping theory. It's an oldie, but it's a goodie. And when we interview patients again and again, this is the one they describe. So this is the one we're sticking with. We have other theoretical frameworks for the dyadic component. But my point here is that we selected what we would refer as a distal outcome, right? We measured the beginning, distress at stage 1 or anxiety. If there's a change, great. But we could have also relied on what we refer to as proximal variables, right? Did they learn something? Did they choose a challenge? They learn a self-management strategy, which means they're like on their route technically to change the distal outcome. So we could have selected a distal outcome, a proximal outcome. Or methodologically, what we'll try to see with tempo, would it make a difference if we chose one or the other? Or you can triangulate. Because you are making some decision measurement-wise at the individual level, right? So a lot of our measures, the psychometrics are established because it's large groups of people that have tested, and there's always the factor of the measurement error. And when you're in groups, the measurement error tends to cancel out. But here you're at an individual level. And we did notice that in some of I have also a SMART that we did for cardiovascular, physical activity among men with cardiovascular issues. And we used the same measure for our outcome measure than we did for our response. And we saw a lot of measurement error. Like even before they got the intervention, they were improving, right? So they're like false responders. So we measured them at screening, we measured them at baseline, and then we measured them at the response. And we noticed that even before the trial, they had decrease already, even if it was just 2 weeks later, and even if the retest is supposed to be okay. So that's why we use screening measures at the screening point and also at the response point. Like we don't use the same measure for our outcomes and for our selection variable. Our tailoring variable, we use screening measures that we would use in clinic. So we use the distress thermometer, the Edmonton Symptom Assessment Scale. So measurement errors, measurement issues is a big, is to be considered methodologically because you are making decision at the individual level. If I think the person is a response and they're not, I'm sending them in different interventions because of that. Same thing for your Cronbach's alpha. It has to be higher when it's at individual level. So this is just the point I wanted to make. Everything relies on that measurement of that tailoring variable, right? So this is my last slide. So there's a lot of advantages. The main reason we're using it is really, if you remember at the beginning, I was talking about pitching that package. What helps us to discern the different components. For us, it's starting to tell us, yeah, we should maybe start with something self-directed, but build. There's a synergistic effect also that you can start testing in smarts. Disadvantages, well, a lot of the questions were about the disadvantage in terms of the large sample size. You do require longer engagement, right? In our pilot, it's small. Someone asked me about the attrition. I didn't see a differential attrition that I've seen in my just randomized control trial of the same interventions. But with the larger one, like that is my main concern because they're engaged twice as long. A regular RCT for tempo would be 13 weeks, whereas now I'm keeping them for 25 weeks, right? So fingers crossed and whatever I need to do, like hopefully we don't get higher attrition than we're planning because there's no budget. I've already used it all. And they can become logistically complex. So I partnered with, like I said, Erica Moody, who's a biostatistician, in terms of the analyses, testing the adaptive intervention, sample size, testing response, and all that. So that's an amazing collaboration that was established there. And I think that's it. So thank you very much. And thank you for all the questions.
Thank you. We still have time for a few more questions.
Okay, so love this presentation. I love your work. I just emailed you to see if you would have any bandwidth to do this in rheumatic diseases because it's what we need. So if I understand correctly, it's one intervention. So I'm thinking of the power because you say you're recruiting 350 people. That actually doesn't sound like a lot of people because you mentioned you're going to have to think about 25% dropout. So you're going to be left with, I don't know, 200 and some people to analyze. So it's like a two-arm study, using the intervention or not. And the nuances of what people are getting, you kind of capture that, but you're not powered to look.
You're absolutely right. Okay, I'm powered for two comparisons, right? So here I need 63 per group, because of my measure and my effect size, and I'm powered here that I hope to be powered, which but I'm not powered for the 4 adaptive intervention, and that is a major disadvantage because the advantage is to test the adaptive intervention, but yet we're underpowered for those comparisons. So I had to choose what comparison were primary for me, and those are the 2. But you're absolutely right. Yep. So I probably need, I don't even want to think about it. Yeah. Yeah. Yeah.
Data that you can use for your next grant application to
Yeah.
say this is a new thing that.
Yeah, absolutely. Yeah. 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 Thank you. Yeah.
Hi, Dr. Lambert. I have a question about the lay guidance.
Yes.
Can you tell me a little bit more about what that constitutes and what lay guidance, the advantage of that? Obviously, cost, that's fine, but I'm sure there were some other ones. Yeah, if you could just speak more about that.
Absolutely. So Jane McCusker is the one at St. Mary's Research Center that initially started developing this guide, and it's on the realization that a lot of the issues are with adherence, and people are not using the intervention. So we don't really need a healthcare professional maybe to just check in on people. So she started testing this model. So generally, it's non-healthcare professionals. We train them more in communication, establishing a therapeutic just calling people and the accountability. So a lot of people would tell us that when we called them, they're like, "Oh, I've just logged in 5 minutes before you called because I knew you were calling." But in the process, I discovered X, Y, Z, right? So it's really, they don't give any medical advice. As soon as there's a medical question, they refer individuals to their healthcare professionals. They use the intervention to respond to questions. They get training in communication. They do get training also in sensitive topics. Like these are people with cancer. So some people, when they call, will either start crying on the phone. So they do get that kind of training. But it's really to establish the accountability of using the intervention. So initially we called it coaching, and then some people say, well, coaching is really just with healthcare professionals. So then we now we're using the term guidance. So does that answer? Yeah.
Thank you. I have a question about data analysis. I know in some adaptive trial, they use Bayesian methods.
Yes, no, we're not using that.
Okay,
Yeah.
so you use frequentist.
Yes, yes.
And I was wondering about blinding and those kind of design.
Yeah, so blinding obviously all of the measures are self-reported by the participants, and they know that they're blinded. They can't be blinded to the intervention because they know whether they get it or not. They're blinded to the hypothesis and what we hope to achieve, and so that's the best we can do. But yeah, there's no blinding, and that beyond that, it's very hard in these trials to blind for. Yeah. So I just want to say in a previous trial of coping together, we actually did, so we had coping together and then we had what we call the minimal ethical care condition, which was to blind, but actually the minimal ethical care condition became more efficacious than the intervention. So then we integrated in tempo. Anyways, we'd made changes. So we did try in different, but with these kind of intervention, it's very, very challenging.
I'm curious still. I'm curious what the percentage of the non-responders in the usual care that all change to tempo group.
We don't know yet because this is the trial we will do. So
do you have a knowledge and prior knowledge that?
Yes. So I am hoping that I'm anticipating, we calculated it here because I needed this for my sample size. Here I'm anticipating 60% response and maybe 40% non-responders.
Then they will go to another group.
Yeah. Well, the non-responders will be offered tempo, yeah.
Yeah. Okay.
Hi, thank you very much. It was a very wonderful presentation. I'm wondering, you mentioned exercise as one of the things that might help. Do you have anything about nutrition, like changing, altering, like, vegetables, fruits, or maybe taking out some things about their diet?
No, and that's something that comes up regularly. So that is a collaboration we're trying to establish with a nutritionist. But for now, we haven't had the opportunity to do so.
Okay, thank you.
So for the physical activity portion, we partnered with Professor Lindsay Duncan in kinesiology. So, I mean, these are all obviously areas of expertise, especially in the context of cancer, but it comes up from patients and has been for, several years. Yeah.
And Sylvie, just talking about physical exercises, what were the most common physical activities
Walking.
that a wide range?
And they get a pedometer and they get, we give them a pedometer. Like now it's not as needed. We only give pedometers to people that don't have their smartphones. And we also give them elastic bands. So we don't prescribe physical activity. So from an ethics perspective, we don't have to get the doctor's approval for them to participate in the trial because we don't prescribe. They choose what they want to do, but most we talk about walking and resistance exercise with the bands. So most of them, it's walking that they choose to do. Yeah.
Well, no questions online? Okay. Well, thank you so much,
No, thank you.
Sylvie.
Thank you for all the
It's been a
questions.
pleasure.